Good afternoon, respected teachers, colleagues, and oncology students. I am Dr. Venkata Pradeep. I work in Assam. Before starting the talk, my 1 minute request to you is that whenever patient travels from far off distances, give some extra time and counsel them a little bit more about the stage, non-curability and all. That will make a lot of difference for them. Today I am given this topic of role of adjuvant therapy in EGFR-mutated early lung cancer. We do know that nearly 1/3 of the patients present in the surgically resectable stage, which is a Western data, and in the Indian tertiary cancer hospitals, the resectability percentage is almost similar, nearly 1/3. Even with that, if we see the 5-year overall survival rates, in stage 1B, it is up to 75%. In stage 2, around 50 to 70%, and in stage 3A, despite the adjuvant therapy, chemotherapy and all, it is only 1/3, that is 30 to 45%. And EGFR mutations, we do know, are the most common oncogene drivers in NSCLC, may it be metastatic or in early stage. Highest incidence is noted in Asia, followed by Australia, around 25 to 30%, and in Western part, which is around 20 to 25%. It was seen that in one of the study quoted here, the risk of recurrence in those who underwent surgery and adjuvant chemotherapy is more in EGFR mutated compared to EGFR wild type. And because of this 5-year survival rate of only 45% to 85%, definitely there is an unmet need of improving the adjuvant therapies to improve the survival in early stage lung cancer. So what are the current recommendations in early lung cancer? So what are the biomarkers? So previously it used to be a panel discussion question whether do you want to test any biomarker in the early stage? The answer is definitely yes. It is EGFR and PD-L1. And this is the Asian consensus on the biomarker testing in early lung cancer. And when we see the prevalence of EGFR mutations in stage 1 to stage 3 lung cancer, NSCLC, more than half of the patients, they harbor EGFR mutations. Nearly 51% of patients had EGFR mutations, out of which most common is del19 and followed by L858R, very much similar to metastatic setting. And in the same study, if we see the type of therapies received, we can see here from stage 1A to 3B, there is incremental percentage of patients receiving systemic therapy in addition to surgery and radiotherapy. But only half of the patients, if we see the total number of patients in the study, only 46% of patients received systemic therapy. And when we see the 5-year follow-up of the study, nearly 50 to 60% of patients does have recurrence, despite all the additional therapies that were given. May it be chemotherapy, may it be radiotherapy. And this is a quoted study by the previous speaker where we have seen that adjuvant chemotherapy does improve the survival. And it is predominantly in stage 3 where the survival improves from 5-year OS rate from 39 to 49%, and in stage 2 from 26 to 39%. That is what chemotherapy does in the resected lung cancer. And what is the historical data of using EGFR TKIs previously? Why there is so much hype about ADAURA? So there are 2 first-generation TKIs that were tried in the adjuvant setting, erlotinib and geftinib. The upper 3 are the trials which have employed erlotinib in the adjuvant setting, and adjuvant CTONG and BR19 employed geftinib in the adjuvant setting. If we see, these are very, very heterogeneous selection criteria. Even stage 1A patients were included in the SELECT trial, and stage 1B, 3A, similar to ADAURA, was included in the RADIANT trial, and IVAN included only stage 3A. And CTONG from 2 to 3A, and 1B again from 1B to 3A. So the selection criteria is not uniform at all. And if you see whether EGFR TKI used instead of chemotherapy or after chemotherapy, again this is heterogeneous. In SELECT trial, erlotinib is used after adjuvant chemotherapy. There are 2 trials, the IVAN trial where erlotinib is used versus against the chemotherapy, and CTONG trial where geftinib is used instead of chemotherapy versus chemotherapy. These are the 2 trials where there is a head-to-head comparison between chemotherapy versus TKI. In the rest of the trials, adjuvant chemotherapy is allowed, just like in ADAURA. So So when we see the overall analysis of the 6 randomized trials, there is a 48% reduction in the risk of disease recurrence. Now, when we try to understand why there is no OS benefit with these EGFR TKIs in the adjuvant setting, the TKIs that were used are first generation TKIs. There are 3 problems with the first generation TKIs. One is efficacy. So most of them, nearly 46% of patients in this select trial, they have recurrence. And when the biopsy was done, it was seen that EGFR mutation is still maintained. And only few of the patients have T790M mutation. Second is toxicity. In the same select trial, nearly 46% of the patient, they needed a dose reduction from 150 to 100. And few more patients have received only 50 mg of erlotinib. So the safety profile is not up to the mark. And second is, when the analysis was done retrospectively, the follow-up at beyond 2 years, most of them developed brain metastasis. So the continuation of EGFR TKI is not done as done in ADARA trial. In fact, we'll be surprised to see the data that at 2 years, if you see the DFS rate in SELECT and EVAN and adjuvant CTONG, it is almost similar to ADARA, up to 88%. But beyond that, the flats rapidly fell. But ADARA continued, both because of the, and in all these trials, the duration was only 2 years of TKI. But in ADARA, we have used for 3 years. So these are the main differences between the historical trials and the current ADARA trial in discussion. And when we see the risk of reduction in disease by the timing or sequence of adjuvant EGFR TKI, so it is seen that adjuvant EGFR TKI, if it is used instead of chemotherapy, it is 57% DFS. And if it is used after chemotherapy, it is even less, 38%. So trials, they have limitations of design, size, there is no OS benefit. And we don't know whether we are really benefiting the patient by using in the adjuvant setting, because there are 2 lines of thought. One line of thought is that because when we are giving in the adjuvant setting in the EGFR mutation, we know that some of the, definitely it is one of the most efficacious therapies available. So we are delaying the disease recurrence, so we are delaying the anxiety as well as the physical disease and associated comorbidities of the patient. But the other school of thought is that maybe some of these patients might never recur, but we are using this therapy only posing the side effects. So they might be missing the opportunity to use when they actually require it in the metastatic setting when they recur and have EGFR mutation. So what we need at this point of time is to understand the molecular biology even better. Maybe EGFR mutation alone will not help us. We need to understand further high-risk cases who definitely need the adjuvant TKI. Is there any additional P53 mutations? Is there any other additional molecular markers which help us in guiding adjuvant TKI post-surgery, not just EGFR TKI? So coming to the most recent trial, that is ADARA trial.
Last 2 minutes, please.
We do know about ADARA trial that it has shown predominant DFS benefit. The criteria is 2 types of EGFR mutation, exon 19 and L85 are included. Please see that 10 weeks without adjuvant therapy and 26 weeks with adjuvant therapy are allowed to use adjuvant. And we can see here the predominant benefit is in 2 to 3A, and there is a significant CNS DFS benefit, which is the main difference between the previous trials and this one. So absolute benefit of 5 years is 12% in 2 to 3A and 10% with when we include 1B as well, in which the benefit is slightly less compared to stage 2 and 3A. And survival benefit is seen even in stage 1B. And the benefit is more in exon 19 compared to L85R mutation. So safety analysis, we do know that there are no deaths related to osimertinib use in the adjuvant setting. So the key takeaway points is, in order to improve survival, we need to understand better. Maybe EGFR alone is not enough. We'll need additional molecular markers. And do you want to test? Definitely yes. And thank you for the opportunity.
Thank you.